I could only agree with Dr. Santana that hepatitis C is a fascinating and I will say speedy field in medicine. If one looks back and tries to see what has happened in a couple of decades, it's a fascinating story. And I am going to be presenting an even more fascinating story that relates to the changes in paradigm of the direct-acting antiviral agents. The WHO has set to eliminate hepatitis C by 2030. And we think that this is possible. I will tell you a little bit later on about what's happening in Mexico, but we're committed to eliminate the disease by 2030 in our country. And one has to make a difference. One thing is to control the disease, which means to decrease the incidence of liver cirrhosis and hepatocarcinoma, as well as the incidence of HCV. The other concept is to eradicate a disease, and the concept of eradication means to eliminate HCV from the earth, and that's a very difficult thing to accomplish. But elimination means zero incidence of hepatitis B infection and decrease of cirrhosis and hepatocarcinoma in a given area. The concept of elimination refers then to the disappearance of the virus in an area, a region, a state, or a country. So one has to make a difference of what are the goals of the WHO for 2030. We're not speaking of eradication, but we're speaking of elimination of the disease. We know that the worldwide prevalence of hepatitis C is important, and it's a health problem, definitely. In Mexico, the frequency of viremic patients is around 0.6% of the population, which implies a little bit more of 500,000 of persons infected with hepatitis C in our country. What happens in the Americas? You can see in this slide the 10 countries which have a higher prevalence of hepatitis C, which is in blue, and you can see that this is the United States, Brazil, Mexico, occupy the 3 first places of the frequency in the number of patients infected with hepatitis C. Relating to the presence of anti-HCV, which one has to call to the attention that this does not say it's viremic patients, but just patients that have anti-HCV, which was used as a marker of prevalence, and that's why I will speak about changing paradigm in hepatitis C. You can see here the frequency in Latin America, and you can see that it is variable. It can go from 0.5 to almost 2%, and similar to what Dr. Santana mentioned, in Puerto Rico, you seem to have a higher prevalence at a specific time. Now, one has to focus in one change of paradigm, that hepatitis C is not a disease by itself, but it's a frequent cause of liver cirrhosis and a frequent cause of hepatocarcinoma. So if we are able to impact the frequency of hepatitis C and eliminate the disease, we're going to have a big impact in liver cirrhosis, which is a very significant problem in our countries, in our region, in Latin America. I'll give you an example in Mexico. In Mexico, Dr. Lozano conducted a study in which he found that hepatitis C is implicated in 28% of the cases of liver cirrhosis in the country, and it's also implicated in 26% of the cases of hepatocarcinoma. So when designing a structure or a program to eliminate hepatitis C, one has to foresee ahead that we're going to have a big impact in the frequency of liver cirrhosis and hepatocarcinoma, and this has helped in our country to construct the hypothesis or the idea to eliminate hepatitis C, but having a bigger impact in liver cirrhosis and hepatocarcinoma. So the first question one has to ask in order to design a policy to eliminate hepatitis C is, do we have an adequate drug to treat hepatitis C? Unfortunately, the answer of that is, and I will show you data, is that we do have adequate drugs. Here is, for example, in real life, the results of sofosbuvir and velpatasvir for 12 weeks, and you can see that it's independent of the genotype, and it's also independent of the degree of liver fibrosis. And that helps to design a politic, to present a plan in order to eliminate hepatitis C. One has to think if we may not need genotype, and we may not need in our countries to study the degree of liver fibrosis. We need them for research, but we do not need them in order to eliminate the disease, if we want to treat everyone. Here you have the other drug, Mavyret, in which you can give for 8 or 12 weeks in real life. And again, as you can see, it helps you in most of the cases independently of the genotype. It has a caveat in relation to liver fibrosis, because in the compensated cirrhosis, we cannot use it in a similar way as we could use sofosbuvir and velpatasvir. But we do have pangenotypic drugs which can allow us to eliminate the disease in the country. So the WHO and the European Association for the Study of the Liver Disease and also AASLD have recommended the use of pangenotypic treatments for hepatitis C. And it depends on each drug if the patient has cirrhosis or does not have cirrhosis, but we have treatments for all of them. And we have treatments in which you can give one dose for 12 weeks, or you have drugs that you can give for 8, 12, or 16 weeks. And this becomes very important in designing a plan to eliminate the disease. So what do we require in relation to the agents, the antiviral agents in the treatment of hepatitis C? We need to have a high sustained viral response. We need to have security, and we need to have tolerability. That means we do not have important side effects with these drugs, and this makes us high priority to eliminate the disease. The second priority is we have pangenotypic therapy. We have a high resistance barrier. We have treatments for short duration that go from 8 to 12 weeks. We have minimal pharmacological interactions, and we have less tablets than what we used to do when we gave interferon, pegylated interferon, and ribavirin. So we can deliver the treatment very easily to the patients, and the provider can also be expanded in the number of people that can treat hepatitis C. So as you can see in this slide, we have things that are essential for the patient, they're critical for elimination of the disease, and the accessibility to treatment. Here you have a difference. In the first part of the slide, in the upper part, you can see that patients that obtain sustained viral response have a significantly decrease in the mortality related to the liver disease or to liver transplantation. And in the bottom graph, you can see the same. People or individuals who achieve sustained viral response have a higher possibility of not developing hepatocellular carcinoma. than patients without a sustained viral response. So that brings us to the question that I mentioned a few moments ago. Do we have adequate drug to treat hepatitis C? And the answer is very simple. Yes, we have now treatments to eliminate the disease, and this is very important to construct an elimination plan, because if we wouldn't have such drugs, it would be very difficult to implement the elimination, and that's why the WHO has made the goal of eliminating the disease by 2030. Now, only 14% of people with hepatitis C in Latin America have been diagnosed, and less of 1% through the region has received an adequate treatment. So the other paradigm that we're facing is we need to search for the missing patients. And the question now comes, we have a drug, but are we prepared to carry out the correct diagnosis of hepatitis C? And I think we are now in the process of being able to diagnose all the patients. We have point-of-care testing, who has different advantages. It's rapid testing. It allows testing and getting the result in the same visit. It can be done outside of the clinical laboratories. It can be interpreted by non-specialists, and it increases the number of patients tested and simplifies the process of confirmation and reference to treatment. We still need to do the viral, the molecular testing, but we don't need to do it in all the population. What we need is to have a positive point-of-care testing and select the population that can go for the test for the viral load. How good is the point-of-care testing for hepatitis C? The sensibility is 95 to 99%. The specificity is 99 to 100%, and results are available in 5 or 10 minutes, and they're very easy to interpret. So by doing this test, we can now have a correct diagnosis in almost 98% of the people that anyway will need to be confirmed by doing the RNA testing of the patient. So all this has led to the WHO proposal of elimination of the disease. So the next paradigm is we need to change our mind from a treatment strategy to the elimination of hepatitis C. It's not the same what we had years ago in the number of patients that we were treating in our region, that the elimination of the disease in the country. I'm glad to tell you this is in Mexico, the numbers of patients, and I'm very glad to announce, for example, that we have convinced our government, and 2 weeks ago they announced that everyone will receive treatment, and we do have a plan for testing, for accessing to treatment without cost to the whole country in order to try to eliminate the disease before 2030 in Mexico. But we need to construct around these paradigms. So what does it mean, the global elimination of hepatitis C? We have programs in many of the countries in our region. We have the direct antiviral agents, and we have the interest of different groups that makes an integral treatment of hepatitis C. We were able to negotiate the price, the diagnosis, the access to treatment, and it took about 2 years to develop a plan to where the patients would need to be treated. So the question of elimination of hepatitis C is, how do you construct that plan? The first question was, with what do you treat the patients? And you treat them with pangenotypic simple therapy. Who treats them? And then you need to expand the numbers of treating physicians. And as Dr. Santana says, we have to move to the general practitioner, we have to move to the internal medicine, and it's not only the people, gastroenterologists and liver specialists. We will be responsible to see those patients that have advanced disease and that unfortunately most of the patients at the present time are arriving late to the treatment. We also need to increase the number of treating centers, and we need to simplify the regulations in the country in order to get access to treatment for everyone. So the elimination of HCV requires to increase the numbers of diagnoses to 90% according to the WHO, and we need to expand the number of people that have access to treatment to 80% by 2030. So the care cascade for hepatitis C is usually very difficult because we have the numbers of patients, the diagnosis was not obtained in a significant number, access to care was even less, patients that access to treatment was shorter, and those patients that attain sustained viral response in the region is very low. Let me show you an example. Here is the prevalence in the region of Latin America. Here is the number of diagnosed patients. Treated patients in 2015 were 27,200 patients, and by 2017 it had increased to 80,000. It's still very low numbers of patients that have had access to treatment. The care cascade, according to the WHO, is we need to have the increased numbers of patients diagnosed, approximately 90% of them, and we need to have 80% of people eligible to treatment in order to increase the sustained viral response to a significant number in order to eliminate the disease in the region. So there are different strategies. One of them is the micro-elimination, which allows for more realistic objectives and goals. It can be achieved in a shorter period of time. It allows for the possibility of tailored strategies. Cost can be predicted, and the prevention of reinfections. I would like to call your attention that in order to construct a plan to eliminate the disease, cost can be predicted, and in order to present to a government, you have to present figures that can convince the government, and in these figures include the decrease in liver cirrhosis and hepatocarcinoma. We did that in Mexico, and that's why approximately 2 weeks ago, the plan to eliminate the disease was approved in Mexico. The models of microelimination includes high-risk populations. We have drug users, people who are co-infected with HIV, migrants, hospitals, prisoners, hemophilia, men having sex with men, transplanted patients, CDs, dialysis, and chronic liver disease. When one speaks in the general population of a prevalence of 0.6, this is not the same in these populations. And therefore, if you target these populations, you're able to be more successful in relation to the cost of the program to eliminate the disease. The other thing has to do with which drug you choose for treatment. And in our countries, a significant problem was the number of tablets that people could take, because compliance becomes very important in the different regions. Usually, we were treating patients coming to the hospital, and now the big paradigm is we have to go and search for those patients, and those are the missing patients that we need to detect. So when deciding which treatment, one has to decide the number of tablets and also the simplicity of giving the treatment with or without food. So the road to simplicity includes, for the patient, probably 1 tablet for a day for 12 weeks, independent of the degree of the fibrosis and the genotype of the patient. And for the physicians, that are not liver specialists and are not gastroenterologists, we need to have a simplified way of prescribing the patients for treatment. And therefore, it's very easy for them if they only have to give it for 12 weeks and not have important side effects. So what do we need to do in relation of hepatitis C? We have to think globally, but we need to act locally. It's a big problem for the WHO, but it's a problem that concerns every country in particular, and every country has to design its plan of elimination of hepatitis C. We need to simplify the treatment because we need to make it very easy for the patients to receiving the treatment and for the physicians or the professionals of health who will be prescribing. At least in our country, we have a huge country and we have a different set of medical facilities, and we need to include the general practitioner in this. We also need to have ideas to transform the system. We are designing. The treatment is going to start to be available in Mexico in approximately 2 weeks because we're being involved in the process of designing a registry for every patient that will receive the treatment. So we need to be able to generate data in relation of the elimination. We need to know, for example, if the numbers of tests that we're doing are adequate and not opening. WHO has decided, for example, that if the prevalence of the disease is less, it's less than 2%, it's greater than 2%, there is no need to do a general screening in the population. It's not cost-benefit to do it. So we need to change from a treatment strategy to a strategy to eliminate the disease. Because if we remain with the idea of just treating patients and not eliminating, we will fail short to achieve the elimination of the disease. And that's what we're doing in Mexico. Our first task is to identify in the population those that are the patients that have hepatitis C, that's 0.6% of the population, in order to treatment, to facilitate their access to treatment. So what would be my conclusions in relation of the paradigms? The first paradigm is that it is possible to go from a treatment strategy to an elimination strategy of hepatitis C. And it's very important in relation on the way that you present the proposal to a specific government in the region. And that has been done in other countries. Most recently, in the month of May, England announced his path to the elimination of hepatitis C. And other countries have done it before, such as Iceland and Australia. And we need to do that in the Latin American region. The second paradigm is that one has to think globally, but at the same time has to look for the specific particularities that each country has. Do we have the people to treat? Do we have the tools to detect the population? And when we negotiate with the pharmaceutical industry, we took all that into concern, and at the same time in the negotiation with the government. It's not only the drug, but it's the need to have access to testing, and we need to have access to centers that can treat the patients. The third paradigm is that the model of care of hepatitis C must be transformed and must be simplified. We were used for many years to treating the patients with pegylated interferon and ribavirin, where we used to have a lot of side effects, and now we have drugs that do not have a side effect, that do not require an excess in laboratory testing. So we need to transform and to simplify the model if we're going to try to eliminate the disease in each one of the countries. And we need an integral model of care of hepatitis C. It's not only the patient and the physician, but it involves the authorities, it involves the pharmaceutical industry, it involves civil society in order to make sure that they help to send the message that hepatitis C is a preventable and it's a curable disease. And that is very important. One has to consider prevention in the concept of elimination of hepatitis C. And I didn't have time to show you, but we have data in prisons where we've done programs for micro-elimination, for example, or in people that consume drugs, and after treatment, the rate of reinfection is less than it used to be before treating the patients. So we need to have a model of care for hepatitis C. And my last slide, which is in Spanish, I apologize, but it's very important to show it. And that is how hepatitis C, in a couple of decades, has gone from the laboratory to the bed of the patients. And it has gone from experimental to the clinic. We're not anymore in the times where we need to have clinical trials. We had them for many years, for several decades, and all these now are replaced by real-time, real-life data. So we've gone from basic to the clinical, and we have a very nice model in this century of translational medicine in a disease. And that takes us to my last message, which is we need to go from cure to the elimination of hepatitis C. And we need to be optimistic because the history of hepatitis C has been a history of success in several decades, and I think it will be a history of success in our regions that need to incorporate and change the concept that it is possible to eliminate hepatitis C. Thank you very much.